Ladies and gentlemen, we now move on to Symposium 12 in Hall B. This is dedicated to immunology, with talks on immunoglobulin demand with evidence-based use, autoinflammatory disorders, and vaccines for the future. It's my great pleasure to invite our chairpersons, Professor Neelika Malavige, President-elect of the International Society of Infectious Diseases, and Dr. Dhanushka Dasanayake, Consultant Immunologist, Medical Research Institute, Colombo.
Good morning, everybody. Actually, good afternoon. Welcome to the Immunology Symposium. It's a very exciting symposium. We've got a lineup of excellent speakers speaking on very relevant things to Sri Lanka and the rest of the world. So without wasting any more time, I think we're already a little bit over time. So I'll hand it over to Dhanushka to introduce the first speaker.
Our first speaker is Dr. Misbah, who is a consultant in clinical immunology at Oxford University Hospitals and the National Clinical Director for Blood and Infection Programs at NHS England. His talk is titled Managing Immunoglobulin Demand and Insurance Evidence-Based Use. Over to you, Dr. Misbah.
Thank you, Dhanushka, for those kind words. I'm delighted to be here. The talk today is to focus on how evidence-based medicine can be used to challenge habit and tradition in medicine. So without further ado, let's go through the slides. Those are my declarations of interest. So immunoglobulin therapy is just one part of the array of different immunological interventions that we're now fortunate to have. So you've got, you can interrupt the immunological synapse right at the top, the interaction between antigen-presenting cells and T cells, the various monoclonals that have been licensed for those targets that you can see, anti-cytokine antibodies in widespread use across a number of specialties. We've now got infusion of regulatory T cells, CAR T cells, chimeric antigen receptor T cells, bispecific antibodies, integrin blockers, which have been transformative in neurology and multiple sclerosis, tyrosine kinase inhibitors, JAK inhibitors, the list goes on, and there's more to come. And immunoglobulin is a soup. We don't quite know how it acts, but it does act. And so we place that. Thank you. So let's focus on immunoglobulin. The total budget for immunoglobulin for the UK is about £475 million. I don't know what the budget for Sri Lanka is. That is huge. And there are a whole array of indications where immunoglobulin is used without evidence. So in the UK, way back over 20 years ago or more in Oxford, because immunoglobulin use was exploding, we decided we would try and come up with a system that was specific to our trust alone to regulate immunoglobulin use. And I'm going to take you through the evolution of that. Okay, that's the slides shifted in. Let's just go back. So this is just to make the case. So how use is challenged? How use is challenged is by peer review through immunoglobulin assessment panels. And until a few years ago, until 2 years ago, the UK had zero self-sufficiency in immunoglobulin. We were dependent on the United States, Europe, and Australia. You can see that over there. And that is not a good place to be, as we can see with the new administration in the US. At the time of the pandemic, there was a great concern about shortages. This is just a snapshot of searches in Google at the time, in the US, looking at immunoglobulin shortages. The major uses of immunoglobulin is broadly used for two reasons. Firstly, to replace immunoglobulin in patients with antibody deficiency who are incapable of producing their own immunoglobulin. So that's antibody deficiency, be it primary or secondary. You then have immunomodulatory use at much higher doses across a number of specialties. Neurology is center stage because there are a number of neuropathies, inflammatory neuropathies, which are immunoglobulin responsive. So that just illustrates the fact over the years, about immunoglobulin use in the UK. The immunoglobulin assessment panels that I talked about basically have a remit. They have to ensure that immunoglobulin use is compliant with evidence-based commissioning guidance. The commissioning guidance is drawn up by multi-specialty experts in consultation with scientific societies. It goes through widespread stakeholder consultation. So it's as tight as you can get. Of course, evidence keeps shifting, so the commissioning guidance gets updated in real time as well. And the current iteration of the guidance is based on, as the slide shows, extensive literature review, a Cochrane scoping review, all of that. So it's pretty scientifically grounded. Right, so the first iteration of the Department of Health guidance had this color coding system. So red meant this was a disorder where there was a risk of death if you didn't use immunoglobulin. So Guillain-Barré syndrome, Kawasaki disease, primary immunodeficiency, you're unlikely to die straight away, but if you don't have immunoglobulin, it's going to contribute to death way down the line. And we have the blue category and the gray category for lesser degrees of evidence. But that has shifted. As evidence has shifted, this guidance has shifted. So in 2018, we revised the guidance and made it much tighter, as you will see in the next few slides. And critically, NHS England, who is the overall commissioning body for specialist services in England, was overseeing what hospitals did. So I'll take you through this slide. At the bottom, the panel just tells you about the template for all guidelines, which is fairly basic. All that clinicians had to do was to mention the conditions, selection criteria, outcomes of review, and dosing. There weren't any rigorous checks there. So there was a lot of variability. There were lots of panels that were just rubber stamping anything. Yes, that's fine, go ahead. In 2018, this was revised, and there are two key a few new columns that have been put in. So you've got to take in the place of immunoglobulin in the treatment pathway for that patient. So if you take a patient with inflammatory myositis, for example, you're not going to look at immunoglobulin in isolation. You're going to look at immunoglobulin in the context of steroids, other immunomodulatory therapies, rituximab, abatacept, all of that. And then critically, there is a column, two more columns. Recommended dose was scrutinized, and also introduce a necessity for prior panel approval. So if you had Guillain-Barré syndrome, you were allowed to prescribe without any challenge because you do not want to hang around with a patient on ITU, or Kawasaki disease. For all the other diseases, there was another layer of scrutiny. So the panels, that's the template for the panels, which started off in Oxford. Because it was so successful, it's been adapted nationally across the whole of the UK. And basically, we have an independent non-prescribing chair, not from immunology or neurology, and my colleague, Professor Brian Angus, chairs the Oxford Thames Valley panel. And then we have the two key specialties are immunology and neurology, and you need the clinical lead for the panel to be fully conversant with immunoglobulin use across all specialties for this to work. We cover 6 hospitals, total population about 2.5 million, where we regulate immunoglobulin use. So let's just look at what effect this has had. Now you might think, if there are any pharmacologists in the audience, that you might think that immunoglobulin dosing has been derived on PK/PD studies. With the exception of a few indications, no, it's an educated guess that's been used. So it's really important to scrutinize the primary data. So, and as I said, the previous iteration of the guidance didn't focus on dosing, or where it mentioned dosing, it was just ignored. Right, so here are some examples of effective scrutiny. I will amplify on ITP in a moment. 1 gram per kg or even 0.8 grams per kg is perfectly adequate to induce a platelet response in ITP. Myasthenia, 1 gram per kg, CIDP. I could go on and on about this. I've given you some examples. So let's look at ITP now. Way back in 2014, we found that our hematologists were prescribing, that red line, they were prescribing 2 grams per kg rather than 1 gram per kg, complete contravention of hematology guidelines itself. And when this data was uncovered, the only way to influence practice was to write to all the medical directors of every single hospital trust in England to say, you have to ensure that your hematologist, with the evidence, the letter came with the evidence to support this, you have to ensure that your hematologist prescribe 1 gram per kg. If you don't, commissioners will not pay you for that extra gram. 2 letters, as you can see the dates, and see what has happened to those 2 lines. They've diverged hugely. And let's just examine what happens next. So already we're saving over £1 million annually, just one disease. This carries on. We're now in 2023, 85% of patients are receiving 1 gram per kg, and only 15% require 2 grams. Huge savings. So how do we know that this is correct? This intervention was met with resistance from some quarters in hematology. Basically, the challenge back was to say, we know what we're doing in our specialty, okay? So what happens next? This was audited very carefully by hematology registrars who have a network, a research network. And what they did was to look at, compared 2 grams per kg with 1 gram per kg, stratified the response in terms of the platelet count at treatment, looked at response and the duration of response according to stratification, and there's absolutely no difference. Okay? So this is really powerful evidence. And if you're still using 2 grams per kg here or anywhere else, that needs to change. Right, in neurology, again, there's been a lot of wastage of immunoglobulin because patients are started off on immunoglobulin for inflammatory autoimmune neuropathies and then just left on it without review. This was happening in the UK until we tightened up on it. So we know a certain proportion of patients with CIDP, that's chronic inflammatory demyelinating polyneuropathy, think of it as the chronic form of Guillain-Barré syndrome, will respond to steroids. For those who don't, they do need immunoglobulin. But critically, a significant proportion of patients, CIDP patients, will go into remission. So you should be able to stop immunoglobulin. And where's the evidence for that? This table is incomplete. I could include 3 or 4 more studies there. So we know somewhere between 20 to 40% of patients on long-term immunoglobulin for CIDP will be able to come off it. So again, important piece of evidence that many neurologists don't, when I say many, let's say some neurologists aren't familiar with, don't act upon it. So they are forced, as a result of this guidance, they are not, the freedom to prescribe is restricted unless they comply. So this is CIDP, the huge level of misdiagnosis. This is data from the US. The pie chart on the left refers to misdiagnosis in US teaching hospitals. The bars on the right refers to misdiagnosis in US community hospitals. You can see that for yourself. The extent of misdiagnosis is staggering. You've got patients with fibromyalgia, diabetic peripheral neuropathy being started off on immunoglobulin. You've got patients with motor neuron disease, amyotrophic lateral sclerosis started off on immunoglobulin. So it does beg a belief, because anybody with any knowledge of neurology will have, how do you misdiagnose motor neuron disease as CIDP? Right, so that was an editorial accompanying one of those research papers in the US. And the editorialist was very diplomatic, as you can see. Look at that last point. where this is the diplomacy coming into play, postulating that misaligned incentives related to the profitability of physician-owned infusion centers, i.e., these are private practice neurologists who are running their centers, who have this incentive to continue. Okay, so we also, our guidance has to be rapid, it has to adapt to new evidence. Unfortunately, during the pandemic, we had this awful but very rare complication with adenoviral vectored vaccines. Completely left field complication, not occurred before. Combined thrombosis, catastrophic thrombosis, usually cerebral venous thrombosis, profound thrombocytopenia, strongly positive with platelet factor 4 antibodies and platelet activation. So that was a huge problem. And because it mimicked heparin-induced thrombocytopenia, the treatment of choice was high-dose immunoglobulin. High-dose immunoglobulin in an intensely prothrombotic condition. This slide just basically takes you through the clinical evolution of a typical case. You have the vaccine. Again, I stress, this is very rare, but only seen with the adenoviral vectored vaccines. It did not occur with the mRNA vaccines, right? So you get somebody, has the vaccine, days, weeks later, develops flu-like symptoms, thrombosis, and they crash, right? High mortality rate as well. I'm just digressing a moment. This was a completely left field complication not known to medicine. How do the regulators respond? I was on the UK Commission on Human Medicines at the time, and we had to respond in real time to this, bearing in mind that if we banned the vaccine straight away, this was Oxford AstraZeneca vaccine, which was the workhorse vaccine for low and middle income countries, the cheapest vaccine available. If we banned it straight away without taking a measured look at the evidence, it would destroy confidence in the vaccine throughout. So this was deliberated on very carefully. So unlike Norway and Germany, who immediately banned the vaccine straight away, we took a little time to issue more detailed guidance. And that's open to criticism. That's a discussion for another time. So to come back to dosing, all the international guidance at this time recommended 2 grams per kg. Remember, this is a condition. This vaccine-induced thrombosis, thrombocytopenia syndrome is intensely prothrombotic. High-dose IVIG is prothrombotic. And we felt very strongly that we didn't want to be infusing as a default option 2 grams per kg on top of an intensely prothrombotic state. So we elected to say it should be 1 gram per kg with the proviso that if patients fail to respond, they would have a further gram. And if you look at the outcome data, again, this is all published in the New England Journal of Medicine, the outcomes in these patients. In the UK, there were 220-odd patients treated, and there was 72% who did well on just 1 gram per kg alone. And this graph just illustrates, with updated JCVI and MHRA guidance, the occurrence of this complication just disappeared. But as far as immunoglobulin is concerned, because we elected to use 1 gram per kg, the UK National Health Service at the time saved about £800,000. Right, so come back to the panel. So we are now challenging senior clinical colleagues who have a huge amount of experience. The panel is challenging them. So how do you do that without alienating colleagues? You need clinical credibility up front. If you're telling people, look, thou shalt not treat, or you don't have permission to do something, you do need clinical credibility. You need to be backed up by your medical director, right? And the panel has to be available 24/7 because patients with Guillain-Barré syndrome or other emergencies, toxic shock syndrome, don't turn up at fixed times. A clear governance process and very clear communication, particularly when you reject an application. And it's really important that the panel is not seen as a rationing committee or as a rubber stamping committee for that matter. So it's navigating this divide is tricky, but it can be done. And you have to be. A panel is not successful if it is not prepared to stand up to colleagues, however eminent they might be, if the case being made for immunoglobulin doesn't have the evidence behind it. So it does generate challenges, colleagues. We get challenges from parents, children in whom immunoglobulin is not approved. Parents aren't happy. Sometimes we get direct challenges. We've had legal challenges as well. So you have to be mindful of all of that in the way you couch your decisions and advice. Right, so let's see what has happened. Across the world, this is a huge problem, trying to manage, regulate immunoglobulin use. This is just one example from Canada. Canada issues very good guidance on the whole. They've done so for a long time across many fields. And as far as immunoglobulin is concerned, you can see this particular slide looks at the effect of 3 interventions. You can see the dates, management guidelines, a toolkit, a guideline update. The detail around the graphs doesn't matter, but immunoglobulin use has not really gone down. The demand management strategies are limited because the guidance is a bit too permissive. It doesn't hold clinicians to account. In contrast, how has the UK fared? If you look at this slide now, on the left refers to the total amount of grams of immunoglobulin used. The horizontal axis tracks the years. And total number of grams of immunoglobulin is on the right. On the left is the total number of patients. So despite an explosion in cases of secondary antibody deficiency, new diagnoses in neurology, all of that, as a result of the updated guidance and strengthening the role of immunoglobulin assessment panels, our use has gone down, and that translates into a 11% saving on a total budget of £475 million. Just reflect on that, huge. Right, to conclude then, we are in an era where clinical autonomy has got to be exercised with responsibility as well. We all have a responsibility to ensure appropriate stewardship of limited resources, whether you practice in a high-income setting or a low-income setting. So what I would suggest is you need some form of peer review. Adapting that to Sri Lanka will depend. You have to look at local factors in trying to devise that. I've got the link to the updated guidance in the UK down there. And then, okay, so this is to end on a philosophical note here. Yeah, peer review, clinical freedom needs to be balanced with equal clinical responsibility. That quote on the right is from John Hampton, was a professor of cardiology in Nottingham, who used to write reflective essays. And he reflected on clinical freedom passing in the context of cardiology, because lots of guidelines in cardiology. I've adapted that to immunoglobulin, to say. And so read the quote at the bottom about clinical freedom dying. So I'm not necessarily saying that we shouldn't be able to prescribe what is required by evidence. That's absolutely fair. But equally, you shouldn't really be prescribing a medicine with limited evidence, however much pressure you might be under. So that might be a bit controversial, but I speak as a clinician myself who has to make these difficult decisions. And there is only a finite pie in any healthcare system. Thank you. I'll stop there.
Thank you, Dr. Misbah, for that. Really, I think there are a lot of questions that everybody is interested in asking about that. But because we are going to have a panel discussion at the end of all three talks, we will save the questions to the end. So I'll like to invite our second speaker, Professor Suranjith Seneviratne, who is known to everybody here because he's been speaking on many forums in Sri Lanka. He's the director for Centre for Mast Cell Disorders and the president of the Sri Lanka UK Immunology Foundation. Over to you, Suranjith.
Thank you very much, Neelika. Thanks for the introduction. And I think there's a bit of an Oxford theme here. Lots of people in this symposium have some link to Oxford at some stage, right? So what I'll do is talk about autoinflammatory and mast cell disorders and just not use a lot of primary data, but give just an update of a very, very vast area. I'll see a lot of immunologists, so I won't spend too much on the time on the basics because I thought there will be a lot of non-immunologists in the audience, and this is a sort of summary that I will touch on, mainly touching on autoinflammatory disorders, and then with mast cell and Ehlers-Danlos syndrome coming into the picture. So you have, we all know that the pluripotent stem cell produces all these different types of cells. You have the T cells that go develop in the sort of mature in the thymus, the B cell in the bone marrow, and the different types of T cells that you have in the that is circulating in our body. Now, the immune system, you find that you have the adaptive and the innate immune system, getting rid of viruses, bacteria, and fungi. And previously, the innate immune system was sort of neglected, but now we know the important role it plays in the general immune pathways in getting rid of these sort of infections. When the immune system gets dysregulated, it produces autoimmunity, allergy, and cancer, and then you have the chemicals that circulate around by which the immune system talks to the different cells, speak to each other. So the important thing to remember here is the autoinflammatory disorders we are talking about is an overactivation of the innate immune system. There is a bit of an overlap there when it comes to the interferonopathies, which I will discuss, but just take it, it's the overactivation of the innate immune system. So the immune system has to get activated, but it cannot run wild. Because if it does happen, it has to come back to baseline. Because if it goes out of sync, then you get these other conditions coming into play. Autoimmunity is a good example where you have response against self, and then you have allergies, response against innocuous substance. So it has to be closely regulated, and the innate immune system being overactivated, you get these different autoinflammatory conditions. Now, these are very complex pathways. I don't want you to concentrate too much on this, but just to give you a feel of the different pathways that immunologists, scientists, etc., have worked on and mapped. So you have the IL-1 pathway, extremely important as one pathway producing inflammation, and that is a key pathway in the autoinflammatory condition. Then you have the type 1 interferon pathway, again, extremely important when it comes to infection, but if it gets dysregulated, you get the interferonopathies coming into play. And then you have the common thing that you have learned from medical student days, the NF-kappa B pathway, again with lots of different sort of mediators and different molecules here, which when they get dysregulated or when they don't function properly, you get disease, and these are the different diseases that can occur. Again, I won't go into great detail. This is an overview talk of this area. And the NF-kappa B pathway has both canonical and non-canonical. So these are the three pathways that have been worked on, and newer molecules are coming sort of every month, newer molecules into this pathway, and then newer defects have been defined with whole sort of the genomics revolution that is occurring in the present day. So IL-1 is the molecule that we are sort of targeting a lot in these autoinflammatory conditions, and you can see the different changes that this can produce. IL-1, if it is dysregulated and if it's excessive. We knew about IL-6 a lot during COVID, etc., and IL-1 is an important chemical. We know about TNF from the rheumatology pathway with regards to TNF. We know that there is a pathway, a chemical acts on a receptor, it signals, and then the nucleus has the effector molecule, effector pathway, effects. So this pathway is called signal transduction, and an important advance several years ago was this JAK-STAT pathway. And knowing this has allowed pharmaceutical companies to try and neutralize some of these molecules. And then we have the JAK inhibitors, which are useful in rheumatology, in other conditions, and also in these autoinflammatory conditions, especially the interferonopathies, those conditions you use this the JAK inhibitors. So that was the importance of knowing it and being able to identify the pathway, because then you can intervene there if you find that the pathway is not working properly. Mast cells have been neglected quite a bit. We have the sort of activated mast cell, then releasing the chemicals and the resting mast cell, and then becoming the activated mast cell. And we had a great sort of understanding from an allergy perspective, but not from any other perspective, where the IgE molecule was found on the surface, cross-linked signals, and then you have the mediators being released. So from an allergy perspective, we have been focusing on this cell for some time, but now it has come in greater importance into different areas of medicine, and I will talk about it a bit towards the end of the slide. Quite complex pathways with regards to the signaling, etc. But just to take home message from this, the basics part is it releases a whole lot of chemicals, and it's not only histamine. It releases close to about 60 or 70 chemicals when the mast cell gets activated and releases a chemical. So you have a whole lot of chemicals that can produce a varied sort of spectrum of effects downstream. In addition, you have a whole lot of triggers that can cause mast cell degranulation. And these are some of the triggers that we look into when people are being diagnosed with conditions such as mast cell activation syndrome, etc. Right, so a clinical case with regards to the autoinflammatory condition. It's a gentleman, 21-year-old male, fever, sore throat, sore mouth, flank pain, myalgia, photophobia, occasional abdominal pain, vomiting, arthralgia. I mean, something we see in clinic. First time, the episodes, he had 3 episodes in the past 12 months, each lasting for 7 to 10 days. So something that clinicians would see. That's 2 episodes when he was 8 years of age, fever, sore throat, tender lymph nodes, occasional after ulcer, no further episodes after this. So he has this grumbling sort of inflammatory phenotype that came in. Things got on examination in multiple oral ulcers, some lymph nodes, some enlarged lymph nodes, tender muscles, skin rash. There was no joint swelling at that time. And these were the investigations. And you can immediately see there was a increased neutrophils, ESR and CRP were the acute phase protein were elevated, ANF, all the autoantibody tests. So the infectious disease team, the rheumatologists, etc., got into action, looking for infections, basically, a whole range of tests, no infective, no autoimmune cause found, malignancy was low, but it was looked at certain basic tests. So what were we dealing with? And following certain other tests, this was where autoinflammatory as a possibility came into picture. And when evaluated, you found that this patient had what we call a TRAPS mutation, the TNF receptor-associated periodic fever syndrome mutation. So this was a typical sort of picture that where you would think of autoinflammatory, you wouldn't, as soon as a person comes with 1 or 2 episodes of fever, you wouldn't think you'll go for the baseline, as I'll talk about in diagnosis, your infections, your autoimmune conditions, malignancy, etc. And then when you're not getting on that angle, you look at the drugs the person is using, and then you will think about the possibility of autoinflammatory conditions coming in. So there are a group of monogenic or polygenic disorders, where there's dysregulation basically of the innate immune system. We have to remember the interferonopathies. There's a little bit of overlap into the adaptive immune system coming with autoantibodies coming in, etc. Key cytokine pathways, interleukin-1, very important, and TNF. There is this inflammasome that is important. I'll show you some slide, and mutation protein associated with bacterial sensing. So this field has really expanded from the time I know Professor Powell in Nottingham was working on TRAPS way back in the early 2000s. And from that time, the Royal Fleet Group has worked a lot on this area together with the NIH group. So some of the conditions, many conditions have been characterized and described now. So this is the sort of a spectrum of conditions. If there's overactivity in innate immune system, you get this autoinflammatory condition. Then you have overactivation of the adaptive, you get autoimmunity. And in the middle, you have a lot of conditions that we deal with, gastroenterologists, etc., deal with, which come in the middle, which has a combination of both inflammation and some autoimmunity coming into play. So again, the spectrum, you have pure autoinflammation, pure autoimmunity, where T and B cells are involved, and then across the range, you have this inflammatory spectrum coming in. Rare monogenic autoinflammatory disorders and rare monogenic autoimmune disorders are at the ends of the spectrum. So this is another way to put this slide. Again, rare monogenic autoimmune disorders, you have ALPS, IPEX, etc., that immunologists would know about. And then you have the rare monogenic autoinflammatory conditions like FMF, TRAPS, etc., which a rheumatologist, immunologist would be with an interest in that area. We'll be looking after, seeing patients and looking after them. Lots of work has occurred in this area. Many advances have occurred. It's just a summary slide to show the advances that have occurred in the area over the last 25 or 30 years. So the present classification, you had the monogenic autoinflammatory disorders. Now, why am I giving you such detail here? Because if you know that there are conditions like this, you would refer to the appropriate person, because these conditions can be investigated properly, honed in on, and then treated appropriately, because otherwise the patient will be getting big dose of steroid just to reduce the inflammation, getting lots of adverse effects, and not making any progress from there. So you have the hereditary periodic fever, FMF, TRAPS, and the MVK defective condition. Then you have the cryopyrinopathies, and this is the range of conditions that you have, including the interferonopathies, which come into this group. So interferonopathies, again, over the last 5 or 10 years have been a massively expanding group of conditions that pediatricians focus on, and immunologists get involved when the referrals come. There are a number of patients in Sri Lanka who have been diagnosed with this condition, where it is predominantly seen by the pediatric team. So if you come back to you have the classification, you have the classic condition, then you have the other conditions with granuloma, the vasculitis type of picture, then you have the interferonopathies. If you come on to the classic condition that we have seen over many years, 20 odd years, you have FMF, TNF receptor associated periodic fever syndrome, and hyper IgD syndrome, together with the cryopyrinopathies. And the distribution of this condition varies a lot. Hyper IgD mainly in the rare condition, mainly in the sort of Netherlands, that area, Western Europe, Northern Europe, etc. But the other conditions like FMF across the world, you can see that. TRAPS is across the world, seen in Sri Lanka, these conditions, and the appropriate testing can be done, including the cryopyrinopathies, Nomid-Muckle-Wells syndrome, seen again at the LRH, quite a number of, I can't say number, there is a fair number of patients who they have suspected, and the diagnosis has been looked at in those patients. Then you have this condition of the group of patients with vasculitis type of patient, with polyarterite nodosa picture, early strokes, etc., which again you have different diagnoses like the SAVI or DADA2 syndrome, ADA, ADA deficiency, ADA2 deficiency, where it can produce early onset strokes, recurrent stroke, or a sort of atypical vascularity picture that doesn't look like the norm that we see in our group of patients that we deal with vasculitis. Number of conditions that differs, interleukin-1 versus interferon-mediated autoinflammation. I won't go into detail because of time constraint, but a number of sort of pointers, clinical pointers that can make you think of one. But again, the age group, etc., is quite important in this group of patients. So a whole range of inflammatory symptoms, which all of you know as clinicians, what group of symptoms they have. And this can be like sort of cutaneous, articular, muscular, pleural, pericarditis, peritonitis, the wide range of symptoms, right? It's having that suspicion of this condition is the most important thing, and it can affect so many different organ systems. And the complication that can occur if you don't treat it properly is you can get AA amyloid, and that is the important thing to prevent. So whole range of different clinical manifestation that you have. The age of onset may give you some clue, but again, that is not really robust at the moment, because, you know, if you'll be talking about the cryopyrinopathies, we are dealing with, especially with childhood or neonatal onset, but the age can be quite variable. Length of attacks, those days in the early 2000s, people used to look at length of attacks, etc., before the genomic ability to do genome studies came into regular use, but again, not very accurate, but traps, etc. It's a longer duration of period of the symptoms occur for, fever occurs for a longer period. And then you have some conditions are autosomal recessive, some conditions are autosomal dominant. I've listed these here, and these are the conditions that we find, including Majid syndrome, again a rare condition, but found seen two patients, and these are the conditions which are autosomal dominant. Important to diagnose this because you have to do appropriate family screening, etc., or family advice that has to be done. And what is the immunogenetics? These conditions were the ones that were initially pinpointed, and the diagnosis where the mutations are found. So you can detect these mutations. You can do a gene chip or whole exome sequencing, but basically gene chip is what is being used mostly in this group of patients. So some have a pyrin mutation, some have a cryopyrin mutation, and these are the common mutations that occur in familial Mediterranean fever, which I think across the world, several teams with an interest in that area would see that. The different mutations in traps, and then again I've put an illustration here, the different mutations that are found in conditions such as DIRA, CAPS, PAPA, etc., the different conditions. So basically, why am I putting this slide? Not to complicate you, but to tell you that there's a whole range of a spectrum of conditions which can be diagnosed. And if you diagnose these conditions, you can appropriately intervene at the correct pathway, correct place, because a lot of them have increased activation of the IL-1 pathway, and anakinra and canakinumab comes into the pathway of using this. What happens if you don't do it and you just give steroids? You get a lot of adverse effects. If you're using big dose of steroid, you do need steroids at some stage. But if you don't reduce the inflammation and the serum amyloid A protein, etc., is very high over a long period of time, then you get AA amyloid, and we know the effects of AA amyloid, etc., on the kidney and other organs system. How do you diagnose? So basically, you can do your inflammatory markers, non-specific, just being elevated, leukocytosis, subtle differences, but having a suspicion and then going for the more specific testing to be able to diagnose the condition. IgD, I just put this slide because, previously they had this tick box system of IgG, A and M together with IgD, and the junior doctors used to just keep on ticking IgD and then load in the lab. It is very rarely used, so it's not a common test that but you will do it in the correct, appropriate circumstance. So if you have a clinical suspicion, you could take a good history, do a good examination, and go through the usual thing, infection, autoimmune malignancy. You are not going to run into autoinflammatory condition as your first possible diagnosis. You will go in, look at those infection, do a good infection screen, but if you are not going anywhere, autoimmune screen and malignancy, then you would look at the family history, etc., and then do more appropriate tests, including genetics, to be able to find out, to be able to work out as to what condition this patient has. What is the treatment? The first treatment, anakinra, is more widely used. Canakinumab is again less frequently used, but the age group is a bit older. Anakinra is about 100 milligrams daily. Patients in Sri Lanka are using it, but some of them cannot afford it to be given daily, so they get it every other day or every third day. Absolutely great. It reduces the inflammation, and it over a period, studies have shown that it reduces the risk of amyloidosis, etc. So anakinra works in one way where it acts on the receptor, IL-1 receptor, while canakinumab acts on the IL-1 beta itself. So two different ways of action, And this shows again that normal signaling of the IL-1 pathway, and then you have canakinumab blocking that pathway and preventing the effects of overactivation of the IL-1 pathway. Studies have been shown to be beneficial in autoinflammatory condition. Canakinumab, published quite a few years ago, has been beneficial across the range of condition, including all the conditions here, very beneficial. And in addition, these were the sort of figures from the paper showing that it was quite beneficial. Most people use anakinra rather than using canakinumab because of cost constraints, etc. And you give it on a daily basis. That is the recommendation. So anakinra, canakinumab, when it comes to early on, if it is you are suspecting sort of FMF-related conditions, you could start off on colchicine, widely used drug in this condition. Again, when it comes to the Mediterranean fever type of condition, at a higher dose, you have to be careful about diarrhea, and very occasionally you can get peripheral neuropathy. I had 2 patients with who developed myopathy with overuse of long-term use of colchicine. But generally, it's a well-tolerated drug, and you'll try to get them off steroids, prednisolone, etc., long-term. JAK inhibitors, again, quite a sort of widely used in several rheumatologic or gastroenterologic condition, will come into the interferonopathies, and it's been increasingly used because it's an oral medication. You don't have to give injection, subcutaneous injection, and that's the advantage of using JAK inhibitors in this condition in certain groups of patients. So next we come on to, that was a quick run through the autoinflammatory condition to tell you that these exist, has to be suspected in the 8 patients that you're not making headway and you're just dosing them with steroid. Because if you diagnose the patient, you'll be able to target their treatment. That's what we want to personalize precision medicine, target the treatment so that their adverse effect profile will be lower. Now, mast cells, again, been sort of in and out of the news for a long period, activated mast cell, releasing all those chemicals, and they have an important role in gastrointestinal disease, in certain gastrointestinal disease, close to the nerves that cause the firing of those. And 4 sort of conditions are considered mast cells in gastrointestinal disease. Gastrointestinal food allergy is an important condition which is probably the more common one, diarrhea predominant IBS, mast cell activation syndrome, and systemic mastocytosis, which is extremely rare. But I just mentioned this as one of the 4 things that mast cells are related in gastrointestinal food allergy. So you know that mast cells with sort of other mediators, etc., play a role in gastrointestinal food allergy, mastocytosis, enterocolitis. This has been a concept that has been there for a long time with the gastroenterologists, but no one has really made much headway until Professor Aziz, etc., at Barts looked at this in detail. He's a neurogastroenterologist, and he has been able to produce quite a lot of studies showing the importance of mast cells in this group of conditions, especially in the gut with diarrhea predominant IBS. Because these are sort of firing pathways showing that it can affect the nerve and how the peristaltic activity of the gastrointestinal. So mast cells, looking at mast cells in certain gastrointestinal irritable picture is important. Then you have this condition called mast cell activation syndrome. I think this has caused a lot of issues in the UK. Some believe it, some don't believe it, etc. I got involved once I went to St. Mary's Hospital, and there was a neurovascular person and quite a few people who were dealing with POTS, Ehlers-Danlos syndrome, etc. So this is a classification of mast cell activation syndrome, quite a robust. This was published about 10 or 12 years ago by Mariana Castells, etc., at Brigham, Harvard, who has been doing quite a lot of work, Peter Valent in Vienna, etc. And then this is a proposed criteria for diagnosing mast cell activation. The important thing to remember is you cannot diagnose mast cell activation by looking at the person's face, because a lot of patients, that's where the problem occurs. Lots of patients think that they have mast cell activation syndrome before they come to see you. So they want you to confirm the diagnosis looking at their face. and they're extremely unhappy if you don't make the diagnosis or histamine intolerant. They're extremely unhappy. So there are tests to be done. There are tests that can be done, which I will talk to you about after that. And then you have mastocytosis as the fourth condition that can affect the gut also. And then you have, in addition, different types of mastocytosis, localized or systemic mastocytosis, etc. So mast cell activation syndrome goes with a range of different conditions. Ehlers-Danlos loss, hypermobility is no longer called Ehlers-Danlos loss type 3. POTS, postural tachycardia, GI dysmorphia are the inter-unit symptom. Range of tests. We have a number of tests that we can do, including prostaglandin and leukotrienes, and histamine and methylhistamine. In the tryptase alone is useless. I mean, there's no purpose doing only tryptase unless you have a sort of a duplication or triplication of the gene pathway, but that doesn't fit into mast cell activation syndrome per se. But just measuring serum tryptase and telling the person doesn't have mast cell activation is not correct, because there are other mediators that you can measure. If you are doing histology, you should measure it properly. And final, last two slides, mast cell activation disorders and Ehlers-Danlos syndrome merged together. Lots of these are our publications, Ehlers-Danlos syndrome across the range, the cutaneous and non, and the extracutaneous manifestations, skin fragility and how you treat it, etc. And the final part in slide is that there is a pathway. If you have mast cell activation disorder alone or mast cell activation disorder in Ehlers-Danlos syndrome, how you diagnose it and how you treat it. So this is a quick run through about autoinflammation, mast cell and Ehlers-Danlos syndrome. And I'll leave you with a lovely slide of Oxfordshire because lots of people have been from Oxford. Yeah. Thank you.
Thank you, Professor Suranjith. Our final speaker is Professor Maheshi Ramasamy. She is a professor of infection and vaccinology at the Oxford Vaccine Group. And her talk is titled Vaccines for the Future. Over to you, Professor Ramasamy.
Thank you very much for that introduction, and thank you to the organisers for inviting me to be here today. These are my disclosures. So can I just start by asking everybody in the room who's ever had a vaccine, ever, in childhood or in adulthood, to put up their hand, please? Great. We are all here because of vaccines. Vaccines are one of the most powerful tools that we have in medicine. In the last 50 years, they've probably saved over 150 million lives. And it's not just infection and death that they prevent due to, or mortality due to infection, they also prevent long-term issues like hepatocellular carcinoma or cervical cancer, which are also caused by vaccine-preventable viruses. They are incredibly cost-effective. For every $1 spent on vaccines, on vaccination, you probably save around $52 in terms of increased productivity and averted healthcare costs. Now, the diseases that these 150 million lives are largely due to the prevention of tetanus and measles, diseases that we don't really see anymore, diseases of the past. We've also eradicated smallpox due to vaccination, and we are close to eradicating polio around the world. Now, vaccination has been around, or the concept of using a part of a pathogen to prevent further infection from that pathogen has been around for a few hundred years and has been described in ancient Chinese manuscripts as well as in Middle Eastern and medieval manuscripts. And this relates to the process of variolation, where you take scabs from somebody who survived smallpox and you inoculate them into the arm of somebody who's healthy. And physicians at the time realized that this actually reduced the risk of developing subsequent smallpox. Now, this practice of variolation was brought to Europe by Lady Montagu, Mary Montagu, who observed this on her travels in Turkey. And this really formed the basis of Edward Jenner's very first ever vaccination. Now, he'd observed that people who worked in the dairy industry, milkmaids in particular, had a very similar disease to smallpox, cowpox, which was much, much milder. So he took scabs from his milkmaid's arm, who was suffering from cowpox, and inoculated them into the arm of the son of his gardener, and then was able to show that the boy was protected from smallpox. Now, since Edward Jenner's first ever use of an attenuated organism as a vaccine, we've got a whole host of new vaccine platforms that are now used around the world. So with improvements in understanding of chemical conjugation, we can now use capsular polysaccharides from bacteria, either on their own or stuck onto a protein carrier to boost the immune response. We can take the actual toxin that causes disease and modify it so it's no longer able to cause disease, but is still immunogenic. We can take proteins from immunogenic proteins from viruses and create a three-dimensional virus-like particle, which can be then used as a vaccine. And of course, the relatively new kids on the block, we have viral vectors, which have been very successfully used around the world, as well as messenger RNA vaccines. And we really have now got vaccines against almost 30 pathogens that are used around the world at different stages of life. Now, the WHO has a very ambitious 10-year plan for immunization, the immunization agenda. And the overarching aim of this plan is to ensure that everybody everywhere is protected by vaccines. In parts of the world where populations are relatively young, such as in Africa, the biggest impact of vaccines is actually in childhood immunizations and immunizing in those first 2 years of life. And we've got lots of data to show that actually this extended program of immunization, or EPI schedule, as mandated by the WHO, has been the single biggest contributor to reductions in childhood mortality over the last few decades. So in young countries, the biggest impact, or in countries with younger demographics, the biggest impact is in vaccinating children. But the world is changing. And in the global north, actually, we have much older populations, and our population pyramids look a bit more like this, where we have aging populations with comorbidities, we have individuals who are iatrogenically immunosuppressed. And we need to think about actually, how do we protect these older individuals? We don't see the childhood diseases anymore because we've got such robust programs against polio and tetanus, etc. We need to think about protecting these older adults who are still vulnerable. In the UK, we have a big program of vaccination against, in particular, respiratory viruses, which are a major cause of morbidity and mortality in older adults. So we use the respiratory syncytial virus vaccine. Now, RSV is a virus that is well known for causing disease in children under the age of 2, acute bronchiolitis, but it's an increasingly recognized cause of viral pneumonitis in the older adults, and we now have vaccines which protect against this. We also routinely vaccinate against seasonal influenza and now COVID-19 as well. We also, in the UK, immunize against shingles, which is reactivation of the varicella-zoster virus. Now, shingles doesn't kill, but it's a major cause of morbidity, and of course is very, very painful. And we see some really interesting results as a result of this. We see, prevention of hospitalizations, reduction in mortality, but with the shingles vaccine in particular, we see something quite interesting. So retrospective studies have suggested that if with the introduction of the recombinant shingles vaccines, we actually get lower rates of dementia. And this is intriguing. We don't really understand the mechanism of this yet. And obviously we need to do a prospective RCT to help actually nail down the evidence for this. But it's not just older adults. We also vaccinate pregnant mums. And here in Sri Lanka, you offer pregnant mums DTP vaccine to prevent tetanus. We observed during the H1N1 swine flu pandemic just over a decade ago that pregnant women actually did really badly from influenza. And so we started offering them influenza vaccines to protect them, to protect the mums from serious viral pneumonitis. But of course, when you vaccinate a pregnant mum, you're also vaccinating their baby, because the mum's antibodies, particularly IgG, will cross the placenta and get into the fetus's bloodstream. And this is particularly important in offering protection to babies in those critical first few months of life before they receive their own vaccines, which normally, the EPI schedule normally starts at around 2 months, and before they're able to mount their own immune responses to pathogens that they encounter. We've used this very successfully against whooping cough. Now, whooping cough is caused by Bordetella pertussis. It's a cyclical disease in the UK. We get peaks every 5 to 10 years. And you'll see from my incidence graph here that we had a big peak in 2010 to 2012. And this was ameliorated by actually introducing a maternal pertussis vaccination program. Which brought down the rates hugely of whooping cough in the first 6 months of life. Sadly, as you'll see, unfortunately, rates are increasing again. And this is a recurrent problem that we see with vaccination programs in the global north. Because we're not seeing these diseases of the past, people become complacent. The public become complacent, physicians become complacent, and vaccination coverage drops. And very sadly, just in the last month, we had a baby who died in the UK of whooping cough of an unvaccinated mother. And this is a vaccine-preventable disease. This should not be happening. In autumn last year, we also introduced the RSV vaccine for pregnant mums. We are still conducting an ongoing analysis of the impact of that, but preliminary results suggest that actually this did have a real impact on acute bronchiolitis admissions in infants in the UK. You can have the most effective, efficacious vaccines in the world, but unless they actually get into arms, they are absolutely no good. And it's a real shame that there are between 20 and 30 million children living around the world who have not received their critical childhood vaccinations yet. They mostly, unfortunately, come from countries which are overpopulated and have health systems under stress, so particularly in countries of extreme poverty and countries where there is internal conflict. And I have to here mention the incredible impact of Gavi, the Vaccine Alliance, which is an international organization funded by governments, which works to procure vaccines, to stop and to provide them to countries, low and middle income countries, so that all children can have access to critical childhood vaccines. The COVID-19 pandemic very much changed how we viewed vaccines and vaccine development. We went from the declaration of the pandemic to having a licensed vaccine that was available and used and authorized around the world in less than a year. And that was an incredible global effort. How do we do it? Well, we had already had these existing platform technologies, mRNA vaccines and adenoviral vector vaccines, which are very much sort of plug and play platforms where you can have a platform where you can insert the gene for your antigen of interest in your pathogen of interest. So you can chop and change these platforms and adapt them very, very quickly to hone in on your pathogen of interest. We had incredible global cooperation from the Coalition for Epidemic Preparedness and Innovation, or CEPI, which funded lots of this research, from the WHO and from UNICEF, which helped to kind of provide the WHO, which helped to provide some of the regulatory framework, and UNICEF and Gavi, which helped to then distribute these vaccines to low and middle income countries. And they formed a fantastic consortium called COVAX, whose sole purpose was to procure and to stockpile and then distribute vaccines to low and middle income countries. And I believe they actually also provided some vaccines to Sri Lanka as well in the first part of the pandemic. We'd also done our homework. We'd also been working on very similar pathogens even before the COVID-19 pandemic was declared. So many people had been working on the SARS-1 coronavirus as well as the Middle Eastern respiratory syndrome coronavirus, which is a respiratory pathogen that causes severe viral pneumonitis and has a zoonotic reservoir in camels. So because we'd already known how to make a coronavirus vaccine, when we had a new emergent coronavirus, we could then pivot very quickly and adapt our existing vaccines to target SARS-CoV-2. So we were starting from a position of knowledge. And finally, we had really clear lines of sight with regulators around the world, the MHRA in the UK, the EMA in Europe, the FDA in the US. Normally, when you run vaccine development program, you do preclinical studies and a phase 1, then a phase 2, then a phase 3. And between each of these phases, you've got to provide immunogenicity and safety data to the regulators, wait for them to review it and get back to you before you can move on to the next stage. And because we had these great lines of communication with the regulators, we were able to feed data in real time directly to the regulators instead of having to wait till the end of the study. And this meant that we could stagger these phases of the study and provide data quickly and rapidly and have regulatory approvals quickly and rapidly. And this sped things up hugely without cutting any corners on safety. So I guess the billion-dollar question is, what is going to cause the next pandemic? The WHO has put together this document which aims to try and, prioritize pathogens for research and development on the basis of their likelihood of causing the next pandemic. And their list is based on a number of factors, including how likely the pathogen is to cause serious disease, whether or not there are any already existing preventative mechanisms or treatments for these pathogens, and how likely the pathogens are to transmit between people, but also from, say, a potential zoonotic reservoir to humans, because increasingly we're seeing pandemic potential organisms are actually derived from animal pathogens. And as humans encroach on animal habitats and we coexist with animals much more closely, there is that chance for a zoonotic crossover. So this is the list of pathogens that the WHO has prioritized, and many of these pathogens on this list will not be a surprise to you. But down the bottom, they listed disease X. And what do we mean by disease X? Well, disease X is the unknown. We don't know. It's a syndrome caused by a completely new pathogen that has not been encountered before by humans as a species. So what could disease X be? Well, this is a map put together by CEPI, the Coalition for Epidemic Preparedness and Innovation, looking at pathogen outbreaks over the last 50 years globally. And you'll see that there are some bacteria on there, MDR-TB, there are some parasites, MDR falciparum. But the majority of these pathogens are actually viruses, and they are RNA viruses. And why RNA viruses? Well, RNA viruses are pathogens that are able to infect multiple species. So there's this real capacity for zoonotic crossover, zoonotic spillover. And they also have a replication-deficient RNA polymerase. So when they replicate, they introduce mutations into the subsequent progeny viruses, which means that there is likelihood for mutations and the emergence of new organisms. And so the likelihood is that pathogen X, which causes disease X, is very likely to be an RNA virus. And so what we need to do is prioritize research within these viral families, and CEPI have prioritized 7 families for vaccine development, which I've listed here. My own research is in the arenavirus family, and I work on Lassa fever, which is a viral hemorrhagic fever, a bit like Ebola, of West Africa, with very high mortality. So CEPI has a really ambitious 100 days mission. And by this, they mean that they want to go from declaration of a pandemic to vaccines in arm within 100 days, even shorter than we did for COVID-19. Now, this is really, really ambitious. And in order for this to actually work, we need to start planning now, before the next pandemic. So what do we do now? Well, we need to develop libraries of vaccines against these 7 different families of RNA viruses, prototype vaccines, so that when the pandemic emerges, we have something that we can quickly modify and pivot to use. We need to build and develop clinical trial capacity so we can test these new vaccines quickly. We need to develop manufacturing capacity because, again, we need to upscale manufacture really quickly, like we did for COVID-19, so we can vaccinate populations globally. Within the pandemic itself, we need to be able to distribute the vaccine, so there needs to be a lot of work done on cold chain. And then after vaccine approval, we need to then be able to test the vaccine and vaccine efficacy in the real world, as well as monitor safety. But it's not just pandemic pathogens. There are a whole lot of pathogens that we already know about that we actually need better vaccines for. So these are just some of the WHO bacterial priority pathogens based on their potential for AMR. And you see that there are some on there that we actually do have vaccines against, like Streptococcus pneumoniae. But increasingly, we're starting to see vaccine escape and replacement of non-vaccine serotypes in nasal carriage of strep pneumo in healthy populations. So we probably need broader valent pneumococcal vaccines in due course. We're already up to PCV20. There are some of these bugs that we don't actually have any vaccines against at all, such as group A strep. We don't have enough vaccines against diseases like Mpox. So the global stockpile of Mpox is insufficient to meet the demand that there currently is for this vaccine. And thinking about parasitic diseases, we have 2 fantastic anti-sporozoite malaria vaccines which are being deployed around Africa, but we don't have any vaccines against blood stage malaria. And this is a hole in our repertoire. So how can we accelerate vaccine development against known pathogens? Well, one way of doing this is to use the human controlled infection model. So in this, we take healthy volunteers and then we expose them to a controlled dose of a very well characterized pathogen. We monitor them very, very carefully for immunological and microbiological endpoints, and when they develop disease, we treat them with rescue therapy. And we can modify this to use, we challenge participants, they recover, and then we challenge them again. And this can give us huge insights, not just into the pathophysiology of infection, but also how natural infection leads to immunity from subsequent reinfection. And of course, from the vaccine point of view, you can use controlled human infection models to test vaccine efficacy. And you can get an early insight into vaccine efficacy in a small number of participants, in around 100 participants, unlike in a sort of phase 3 vaccine efficacy study in the real world, where you'd need to recruit 20 to 50,000 participants. So this is a really neat, controlled and careful way of accelerating vaccine development. And in Oxford, we have a number of controlled human infection models that are up and running and have been for over 15 years now. So we have a malaria challenge for both falciparum and vivax, where participants are bitten by infected mosquitoes or infused with infected red cells. And this has contributed to the studies that then led to some of the sporozoite vaccines, which are now being deployed in Africa. We have respiratory challenge models with viruses, including SARS-CoV-2 and respiratory syncytial virus, but also pneumococcus and bordetella pertussis, the causative agent of whooping cough, where we inoculate directly into the nostrils. We have enteric challenge models where we give participants a suspension of salmonella to drink. And this was pivotal, the Salmonella typhi enteric challenge was pivotal to the WHO pre-qualification of the typhoid conjugate vaccine. And up on the top left is a graph from our soon-to-be published New England Journal paper on the first ever efficacy of a paratyphoid vaccine. But we're not stopping there. We're developing new challenge models, and this includes an E. coli urinary tract challenge model, a Neisseria gonorrhea STI model, a Staph aureus skin infection and colonization model, and a Group A strep upper respiratory tract model in collaboration with the Murdoch Institute in Melbourne. And hopefully I can come back and tell you about those in due course. But I think as a vaccinologist, the thing that upsets me most is the rise of vaccine skepticism over the last few years. You'll be aware of the terrible cuts to vaccine research by cuts to NIH and BARDA that are happening in the US. The really depressing withdrawal of funding from many states of Gavi, which is a real shame. You know, this will really impact the delivery of childhood vaccinations to low and middle income countries, as well as sort of a real suspicion of independent experts around vaccine programs. And this has real consequences. This sort of messaging means that vaccine coverage is falling. So this is CDC data about coverage of against measles in the US, and you'll see that there are many states that have less than 90% coverage against measles. And what does this mean? Well, it means that actually measles is coming back in the US. And very sadly, we've had 3 children die in the US of measles, and we've had over 1,500 cases of measles in the US already this year. The real-world impact of vaccines cannot be overestimated. Vaccines save lives, vaccines save money. We cannot let our future look like our past. In Sri Lanka, you have a really robust vaccination schedule, and you have absolutely fantastic coverage rates in the high 90% for childhood immunizations, and that really is something to be proud of. So I'm going to finish off by encouraging you all to be vaccine advocates, to talk to your patients, to talk to your family and friends, to talk to your communities, to kind of drill home just how important vaccines are and what great tools they are. Vaccines save lives. If you'd like to direct any of your patients to any resources that are written very much in sort of lay language to kind of help people demystify vaccines more broadly, but also against specific diseases, I can recommend these 2 sites, so I'll just Google them. Thank you very much.
Thank you, Maheshi. We would invite all the speakers as well on the stage for the panel discussion. Professor Ramasamy, Dr. Misbah, and Professor Suranjith, please. And the other panelists.
I would also like to invite Professor Shiroma Handunnetti, Professor in Immunology from IBMBB, University of Colombo, Dr. Mario Alles, Specialist Medical Microbiologist, Faculty of Medicine, University of Colombo, and Dr. Praveen Weeratunga, Senior Lecturer in Clinical Medicine, Faculty of Medicine, Colombo. If you could join us.
So without waiting any time, I think it's important to kick off the panel discussion. I'm sure a lot of you have questions after listening to these 3 talks, which were very different. But I'll first like to ask our panelists from Sri Lanka, given the challenges and the developments and the change in landscape when it comes to therapeutics, vaccines, and also diagnosis and a better understanding of immunology diseases. So I'll first start with Mario here, because he has returned to Sri Lanka recently after training in immunology in US. So given all these changing landscape in immunology and rapid development of various types of immune-based treatments, not just for immune-mediated diseases or neurology, but for infections, cardiovascular diseases. How do you see Sri Lanka, riding the wave? Or, I mean, we're obviously lagging behind, but how do you see Sri Lanka, going along and strengthening our immunology, clinical research, clinical, like guidelines and implementing these things?
Thank you. That's a very good question. So, as someone who just returned from the US, having done a lot of immunology-related research, at least with the previous administration, they were focusing a lot on not just infectious diseases, but the non-infectious comorbidities of infectious diseases, specifically in the context of HIV, which is still prevalent, and even SARS-CoV-2, how these chronic diseases and even acute viral infections can lead to problems like cardiovascular disease and the immune basis for that. So there's a lot of research going on in that regard. Now I know in Sri Lanka, immunology is still in its infancy, but for us to develop upon this immunology, the whole develop upon immunology in Sri Lanka, I think it is collaboration with foreign institutes. Now, for example, we have brought some NIH grants working on HIV and cardiovascular disease. So we are working on that in Sri Lanka, similarly with regards to SARS-CoV-2 and its relationship to cardiovascular disease and diabetes mellitus and things like that. So again, we need resources, we need funding, we need good backing from foreign collaborators, and again, collaboration. That is the key to us developing as a country in terms of immunology in Sri Lanka. Thank you.
I would like to ask Professor Handunnetti now. Professor Ramasamy showed a long list of diseases where vaccines are needed, but we see a lot of diseases like leptospirosis causing a lot of morbidity and mortality in Sri Lanka. So I don't think it even enters this list. So how can, as a country, we contribute to this? Is there any way that we can go forward in introducing vaccines for these basically neglected tropical diseases?
Thank you. Actually, we are still yet to accept leptospirosis as a neglected tropical disease. It's still not in the WHO list, even though we have a huge morbidity and mortality, I would say, almost equivalent to dengue. So there is a lot of research needs to be done. And I think there is some research going on in the different aspects like pathogenesis and looking at different factors that affects the pathogenesis. But in terms of making vaccines, I think it's in its infancy in Sri Lanka. And if you look at the leptospirosis vaccines, you first need to know what seroas that are prevalent here. Because if you look at the global context, there's only 4 countries which have licensed leptospirosis vaccines, and they're only looking at different specific seroas which they prefer for their particular countries. So if Sri Lanka needs to look into or put an effort into getting leptospirosis vaccine, so that's the basic level that we need to cover to see what seroas that are prevalent, and then work on them and to see how it will be common to the region, because you can't just make one vaccine just for a particular country, because it has to be economic in the sense because it has to get marketed. So there's a lot to be done. I think we are very much at the infant stages, and I would think that collaborative research would encourage this aspect.
Thank you, Professor Handunnetti. So this question is for Dr. Praveen Weeratunga. So I think both previous panelists made it very evident that immunology is very underdeveloped in Sri Lanka, but it's a very rapidly advancing field in all aspects: diagnostics, therapeutics, vaccines. And one of the aspects, this is just my personal view, that stands in the way of moving things forward in Sri Lanka is the lack of knowledge, awareness of basically immunology among doctors and clinicians in Sri Lanka. What is your opinion, and if you agree or disagree with this, what are your reasons and how do you see the future?
Yeah, I think immunology education in undergraduate and postgraduate curriculum needs a little bit of a paradigm shift. At the moment, so this is well described in neurology, neurophobia, you've heard of it. Same thing applies to immunology. The moment people start thinking of immunology or learning immunology, you put up a complex mechanism on there with lots of chemical names on there, and they just shut off. So we are exploring newer ways of delivering basic immunology knowledge to medical students. Actually, including immunology in the curriculum itself is a challenge, because people do not see the relevance of this in their practice. So we have introduced some sort of basic immunology teaching in the curriculum. And of course, always trying to make it, why is this relevant to you as a practicing doctor? So that's where you start. And I think the future, most of the future doctors, people who are medical students now, will prescribe more and more immune therapies in times to come. And most of the diagnostics will also be immune-based. So I think sort of focusing on that is what the plan is. And also delivering it in a newer way to the newer generation of learners is also something that we need to look at, rather than complex mechanisms in, say, Jane May's textbook of immunology. Just deliver it in a slightly different way. Yeah, thank you.
So thank you for that. And I would like to open the floor for questions for our speakers. I'm sure there are, especially, yes.
Can I ask Professor Ramasamy, is there any evidence whatsoever for an association between autism and whatever the vaccines, which is the current topic in the USA?
Absolutely none. So this, of course, links to the discredited Dr. Andrew Wakefield, who suggested that there was a link falsely suggested that there was a link between autism and MMR. And that has been extensively disproven. There is absolutely no link between those two. But that sort of fake news narrative has really damaged trust in vaccines, and that's the narrative that is partly behind the falling measles uptake rates that we see in the US, and then the knock-on effect of measles cases rising. It's such a shame.
So why isn't there a bigger outcry among the medical profession there against this? Few people have been saying against it.
I agree. I think it's quite difficult, politically. And I would encourage all of you to, as I said, to be advocates and to kind of, communicate that this is fake news, because, people trust their doctors. Your family members trust you because you're a doctor. And what you need is a good, reliable source of real information, of real facts.
Just add in one point. You go and look at the newspapers today. What do you see? People have been killed, accidents, someone has died somewhere. People like bad news. So when you have a vaccine that is good, people don't accept. But if you say that something causes dementia or something like that, they just jump on the bandwagon and try to ride it.
So I think we have come to the end, and I realize Suranjith's point. I think a lot of people just like bad news, especially in our countries. Although there are good things being done, it is not highlighted. And I think CCP hopefully can change this trend, at least among doctors, where we have looked towards positive things and how we can evolve, because we are talking about, after all, this is an immunology session. If we don't evolve and move with the times, we perish, right? So we don't want to be left behind. So I think, as everybody highlighted in their talks and their ideas, hopefully we can take these things forward. Thank you.
Could I now please invite our chairpersons to award the certificates and letters of appreciation to the speakers and panelists. Could I now please invite Dr. Yapa Udayakumara to award the certificates and letters of appreciation to our chairpersons. Excuse me.